Thank you, Dr. Sam. Thank you very much. Next speaker, Dr. Ali.
Next speaker, Dr. Professor Mosaad Soliman, covered stent graft for treatment of carotid artery aneurysm.
Good afternoon. One of the cases that we need to cover is the carotid artery aneurysm with a kind of a covered stent. Yes. So when it comes to the atherosclerosis, we will find that atherosclerosis is responsible for the development of strokes in 10 to 15% of the cases, and every attention should be made toward prevention of the stroke, either through the best medical therapy, or we can choose the CEA, the carotid endarterectomy, in the aim of reduction of ischemic stroke in these patients in 10 to 15% of the cases, only when they are symptomatizing, and also in patients with failed best medical therapy. Then it is the era of the CAS, which is widely accepted as an alternative to CEA. And the CAS is being used in symptomatizing patients with high grade of stenosis and deemed to high medical risk to undergo open surgery, or when there is some anatomical limitations as in inaccessible lesions, highly situated restenosis, or in cases of neck radiation. With the development of technology, we had either the bare metal stents, covered stents, tapered stents, or free cell stents. And the self-expanding stents seems to be the cornerstone for every kind of protection because of the chronic compressive forces applied in the stenosis, in addition to the discrepancy in the size of the internal carotid compared to the common carotid and the mobile nature. So in the list of potentials for uses of the covered stent in the carotid, it is the same as every lesion somewhere else, like in the cases of trauma, dissection, true aneurysms, false aneurysms, and in cases of stent restenosis. Nonetheless, there is no commercially available approved covered stent to be used in the carotid area. In this case, we had this 65 years old folks with diabetes, smoking, and suffering from ischemic heart disease, and was prepared for CABG. And during the preparation, the routine Doppler in the carotid have shown this kind of fibrofatty eccentric lesion affecting 70% of the internal carotid with the proximal part of the internal carotid artery, and post-stenotic dilatation in addition to an attenuated segment of the internal carotid running far towards the high up in the neck. So the same findings were proved by CTA, and a basal CT of the brain didn't show any acute or unestablished former cerebral infarction. So we ran through the option of using the stent pathway, the CAS pathway, instead of the CEA because of the comorbidity of the patient needing a CABG and in need for general anesthesia. So the CAS was the best option, and we started preparing the patient with a clopidogrel in a loading dose of 300 milligram. Under local anesthesia, we ran the guide wire towards the carotid, and we negotiated in the area. Was that easy, passing through the area of stenosis, and we have reached to the base of the skull, crossing the attenuated segment distally. And at that time, we had to run a diagnostic angiography to confirm the left common carotid and the internal carotid stenosis inconsistent with the ultrasound and CTA. And we deployed the kind of covered stent from the attenuated segment distally to the proximal common carotid, and we used the Advanta V12 in a size of 6 by 60 millimeter to cover the area of the stenosis, post-stenotic dilatation isolation, and the attenuated distal segment. And at this level, we have the concern because of the discrepancy in the size of the stent. So we intentionally dilated the stent distally at 4 millimeter, and at the site of the aneurysm at 5 millimeter, and proximally at the common carotid at 7 millimeter. So this dilatation was intentional by the balloon from different sites because we don't have the tapered stents, although the Covera stent, which belongs to Bard, is a tapered stent, but it is not available in that size. It's only 6 distally, so you cannot reduce the size at this level. So we had this picture, good flow distally. We had a CT brain that didn't show any kind of embolization in the peripheral territory, and the patient went uneventful for the first months, and CTA 2 months later showed the same. So what we had in plan to isolate all the particles in the area of the stenosis and the post-stenotic dilatation, because this is a major part in embolization in the peri-procedure period, and also 1 month later, these particles can go through the struts in the bare metal stent, and it is a major impact for the development of peri-procedure cerebral stroke. It is all about the fragments that goes in between the struts, causing distal embolization. So the idea was to isolate all and press it against the vessel wall, preventing distal embolization. So the main advantage in this covered stent was its simplicity and the cost saving, because you don't use any filters as a protection device. And strokes have been reported in 24 to 30 days post-procedure just because of the embolization of the particles in between the struts. And it has been reported by Shainozaki that by IVUS, there is an incidence of struts in between the struts embolization and the bulging of the material in 7.8%. So to take our home message, CAS with covered stent offers a fast and a single-step procedure, despite it is not popularly used because there is no such dedicated covered stent for use in the carotid. Thank you very much.